That was pretty exciting, right? When I agreed to do this, I didn't know I was going to be following Governor Pence. So, all right, let's see if I can figure out how to use this stuff. That wasn't correct. Let's try a different button. All right, so you may have seen me on TV, you may have seen me in newspapers, and I don't look like that person. So just a quick explanation. I let my hair grow for a period of time, and it just happened that Austin caught the national attention at that very moment. So this is my normal look. Whatever you saw on TV and newspaper was a really bad experiment that went terribly wrong. I want to talk to you a little bit about what we've been dealing with in Austin. And before doing that, I just want to mention a couple things that I've come across. And I want you to keep these thoughts in your mind as we go through what we've been dealing with in Austin. I'm going to move it. So you all probably heard about the rat experiments in the 1950s, where they took a rat, put it in a cage, gave it a choice between water by itself or water with an opiate. And we all know which bottle that rat consistently chose, right? Which one? Hello? Opiate, right, very good. To the point where it would neglect everything else in its life and it would eventually die. This formed the framework of what we thought of addiction for a long time. There's a really bright guy named Professor Bruce Alexander in the Netherlands who was thinking about this study and looking at it, and he realized that rats are social creatures like ourselves, and looked at the design of the study and realized that these were rats in isolation by themselves with nothing to do except for drink water or drink opiates. And he thought, maybe we can design this experiment a little bit better. And so in the 1970s, he set out to do this. And he took two sets of rats. One set of rats he put in the normal cage by themselves, no other rats around, nothing else to do, gave them a choice between the water and the opiate. The other set of rats, he developed something that he called Rat Park. And what they wanted to do is give everything that a rat would want in life. Other rats, a soft place to snuggle into for the night, a place to exercise, these sorts of things. And they looked at the two groups of rats, and they gave them the exact same amount of water, the exact same amount of water laced with opiate. And he found an interesting thing. The rats in isolation that had nothing to do, they chose the opiate water. The rats in Rat Park, they didn't. They liked the regular water. They had other things to do. They had socialization. They had, playing in the mulch that they put in there and walking through tunnels. And if they drank the opiate water, they were too stoned to do anything. And they didn't apparently like that. So they chose the regular water. Where are we? So he argued that this discovery challenges both the conservative notion that it's a lifestyle choice and choosing to party, and the more liberal approach that it's all genetic and it's a neurologic pathway that changes forever when you get exposed to an opiate. And he put out the challenge that maybe actually addiction is adaptive, and it's more about the cage than the individual. So one thought I want you to keep in mind as we go through things. There was this other pretty inventive guy, Vincent Felitti, maybe, in San Diego. He was studying obesity, and he was looking at 30,000 people, and he came up with an interesting discovery that most of the people he was working with had some sort of childhood trauma, many times sexual abuse. And he thought, well, this is interesting. So he developed a different study, looking at 17,000 people, called the ACE study, Adverse Childhood Experiences Study. And these are the childhood experiences that he thought were adverse, and I think we would mostly all agree with these. Verbal abuse, physical abuse, sexual abuse, and others. Many mental illness in the home, a family member in prison, substance abuse in the home. Think of these as we're going through our slides with Austin as well. For individuals that had 6 or more adverse childhood experiences, get this, 4,600% more likely to become addicted to IV drugs. 4,600 times more likely. Who's going to sign up to do something that's going to increase your risk to use drugs 4,600% more times? What are we willing to do to change a child's experience so that doesn't happen? I want us to think about this as we go through the slides of Austin as well. He stated, oh, this is a different guy. Dr. Mate, he's a leading expert in addiction medicine. By the way, I turned 43 last year, and when I did that, my ophthalmologist told me, or my optometrist told me it was time for bifocals. I wasn't really agreeing with him, but he said, let's try it out. So he got me these glasses that the bottom part, you can see close, and then the top part you can see far away. So I'm trying to find the right aim to see the screen down here. So if you see me doing that, it's not that I'm agreeing with myself, I'm trying to see the screen. Okay? So Dr. Mate, he said that we take a group of individuals who've been traumatized in their childhood, and then we lead them into a lifestyle where they continue to be traumatized through us stigmatizing them, locking them up in prison, separating themselves from their loved ones. And he said that if he had to design a system that was intended to keep people in addiction, I'd design exactly the system that we have now. There's a different guy named Professor Peter Cohen, and he recently wrote an article where he argued that human behavior, one of the most important things of human behavior is our bond with other people. He said that connection is one of the things that defines who we are. And if we lose that connection, then we're at risk of connecting with other things instead of people, whether that's the roulette wheel at the local casino, or a needle that we inject in our arm, or whatever that may be in our life. Netflix, watching too many episodes over and over again, and we go to work the next day exhausted because we stayed up all night. And we say, we'll never do that again, yet 3 weeks later we do it again. Or maybe it's the Diet Coke that we have to have in the mornings. I don't know. We all have something probably. But when we don't have that deep connection with people, we turn to other things to connect with. And he said something that was rather interesting I had never heard before. And that was that instead of thinking of addiction, we should think of bonding. And so when we see people that are suffering with addiction, it's really that they are bonding with something different. I want you to think about that too as we go through what we were doing in Austin for this past decade, and then more significantly over this past year. So I found this quote from a local historian. It says that Austin was the focus of media all across the state. The publicity of the town was not positive. Indianapolis papers portrayed the town as a downtrodden town, and a town run by a bunch of ruffians. I thought, well, that about wraps it up. That was written in 1954. We've had a long history of issues in Austin. It's a rather rough town. A lot of its roots originate from Appalachia. I'm not sure if you are aware of that or not. But a group of people from Appalachia migrated up to Austin to work at the cannery when it opened at Morgan's Foods. And so there's a deep culture there that originates from Appalachia. Poverty and substance abuse has been generational. In 1954, a Madison newspaper called it Pistol City because of a lot of the gun activity that was going on, and it's kind of stuck, and it's still known as that today. Austin is sort of a tale of two cities. There's the really rough generational poverty, substance abuse city, and then there's this really beautiful, thriving city that produces amazing individuals like my office manager, Jeannie. It's a beautiful city, it has beautiful people, and it's really interesting to see those two cities sitting side by side. All right, so I opened my practice in 2004, and right away I knew I was in over my head. There wasn't a doctor there at the time. I opened my office, and some of the first things that I saw were only in, I'm not sure if you know what Robin's pathology textbook is, but it was something that we studied the worst case scenarios of disease presentations. And I was seeing this in my clinic. A guy came in with a tumor on his tongue that was so big he couldn't close his mouth. And he just walked around with a cloth to catch the saliva coming out of his mouth. This is the way he lived. I opened my office, he came to me for help, we got him help. He lived another year or two, more dignified because the tumor was removed and he was able to close his mouth finally and interact with his family a little bit better. But these are the sort of things that I was seeing when I first opened my practice, not to mention the deep-seated substance use that was going on around my office. In 2006, I reached out to the Indiana State Department of Health for help, and we began to work on getting Scott County designated through IRHA. In 2007, I hired a nurse practitioner. That's one of the requirements to become a rural health clinic. And we moved down the process to get that designation once the IRHA designation came through. Also in 2007, the INSPECT program began. And you all know some of the results that have come out of that program where we can track things a little bit better. And what we've discovered is that Scott County has the highest per capita prescriptions filled of oxycodone. That's filled, not prescribed. It's misleading to think that Scott County prescribes a bunch of prescriptions for painkillers. We don't. It's actually coming from outside of Scott County. We've tracked this down, and we know that the vast majority of the opiates are coming from out of the county. Opana was the drug of choice, is the drug of choice. There's no one in the county that even prescribes Opana. You all know a lot of this information already. Indiana's in blue, national is in, what color is that? Magenta? Red? We'll call it red. Blue and red. We're above national averages in every age group for using prescription drugs. These are the number of people in treatment. Again, we're above national averages. This is from 2012. The state looked at counties that needed help with dealing with prescription drug abuse. Interestingly, you don't see Scott County on there. It's actually in the top 25th percentile, but it didn't hit the top 10th percentile to target it as an area that needed help. So, again, we missed out on some help there. In 2008, we received our rural health clinic status, and we started reaching out to multiple community health centers for help, especially community mental health centers for help. We just kept calling, having meetings, letting people know that there was something bad happening in Austin and we needed help, and unfortunately that help never came. Significantly in 2010, Opana was reformulated to be non-abusable. What this meant was that people who were crushing it and snorting it to get high couldn't do that any longer. Being the inventive people that they are, they found a different way to get high with Opana, which was melting it down and injecting it into the vein. 2011, we recognized locally that we had a sudden increase in overdose deaths that we thought was related to the change in the route that they were administering their drug. In 2012, this attention was put out even more through a national article written by Reuters, chronicling the rise of OPANA in America, and they specifically targeted Austin as a place that needed help. So in 2012, I did have a couple nurse practitioners that would occasionally prescribe OPANA, and we put it into that completely. There's been no prescriptions out of our office since 2012 for OPANA, and as far as I know, no one in the county has been prescribing it since then as well. Also in 2012, we educated our first responders on identifying overdose, got them trained on administration of Narcan, and we started to see our overdose deaths decline, although we were still seeing a significant number of overdose through the emergency department. Also in 2012, a lot of this came from that Reuters article, honestly. When you get in the national news, you want to do something about it. You don't want negative press. So these are some of the things that we were doing. The next thing was that Dr. Avery in Scottsburg and I, we got together and met with the CEAS representatives there, and we proposed to the rest of the medical staff in the county that it would be a good idea, since we have some bad press, to get some good press out there, and for all of us to pull together and publicly take three pledges. One was related to opiate administration. It pretty much matches what the state's adopted recently. The next one's on tobacco, and the third one on alcohol. Unfortunately, it was not adopted. But Dr. Avery and I did implement the principles of those pledges into our practices. 2012, new rules came out for pain clinics as well in Indiana, and there was some crackdown on the way opiates were prescribed. This did result in a decrease in prescriptions for opiates statewide. Unfortunately, the incidence of opiate addiction continued to climb, and the number of deaths related to overdose continued to climb in Indiana as well. Went from 13.1 per 100,000 people in 2011 up to 15 per 100,000 people in 2014. 2013, we had grown enough to where we needed a larger building, and we wanted to start doing more specialized care. At that point, we felt like we were doing a pretty good job of meeting the basic primary care needs, vaccine for children and other programs. We were able to perform on a pretty consistent basis, where most kids were immunized, most families were getting screenings. Another thing that we were seeing a lot when we first opened is like cervical cancer. You shouldn't see girls dying of cervical cancer, but we were. That really isn't the case anymore. Most of the screening is getting done. So we moved over to this larger space to try to start providing more specialized care. Develop a diabetes center, bring in a women's health specialist, heart disease, and those sorts of things. Is there somebody that's going to talk to me about time, like give me a 5 in the morning or anything? Is that you?
I can do that.
Okay, all right. Let's see. 2013, I reached out to Leslie Holbershorn at the Department of Mental Health and Addiction. She's one of the 3 addiction psychiatrists in the state. Asked her for help. She told us about a program that hits adolescents for addiction. We started working towards developing a telemedicine program with her. 2014, we applied for it, received the ESPER grant. And they're right over there, and I encourage you to go talk to them. So that pretty much brings us up to the end of 2014, and that's when we started seeing the uptick in the HIV epidemic in and around Austin. So we're dealing with generational poverty and trauma to young families that date back for generations, at least the 1950s. Prescription painkillers continue to increase in prevalence. Lack of adequate public spending contributed to this. Defunding and closures of much needed programs to meet people where they were and help them move on with their lives. Lack of mental health and addiction services, change in the OPANA formulation, and public policy of possession of needles all contributed to the situation that we found ourselves in. We talked about the generational poverty, prescription painkiller escalation. We all know about this. And I'll just move through these fairly quickly. We all know that there's been a rise in prescription opiates. But how about benzos? We don't talk about those much, but they've been increasing as well. And how about as we've been cracking down on opiates, we're seeing a resurgence of heroin. We're right in the purple is bad. You can see where we are. For every 10, for every 1 overdose death, there are 10 people who are in treatment, 32 emergency room visits, 130 people addicted, and 825 that are using opiates for non-medical purposes. Lack of adequate public health spending. I'm sure you guys are very familiar with this as well. Indiana's per capita state funding for public health dropped from the 37th percentile, or the 37th state, down to the 45th state in 2014. Federal spending from both HRSA and CDC are in the very bottom as well for the entire country. We're 48th and 46th. There's only 52 states, right? Let's see. So Scott County is one of the poorest counties in Indiana. So you're talking about one of the poorest counties in a state that has some of the poorest public health spending in the country. Defunding and closures of much needed local service providers. This is basically a quote from somebody that's been operating in Scott County for about 30 years and has done a lot with grants and such. The past few years with the economic downturn has been very difficult. We've seen a lot of really wonderful programs that have taken us from the bottom, started moving us up to where we were doing a little bit better in the late 1990s, early 2000s, and then we've been coming back down as program after program after program has been defunded. We were giving space away in my office for GED programs. They couldn't come back anymore because they couldn't even pay a staff member. We had a connections program that was working with early moms, giving space away for free so they could be in there to do education, train moms, talk about smoking cessation. They couldn't come back anymore because we lost the grant. I could just name program after program that has been that way. But the bright spot is that we realized that working in silos wasn't working. If one program had a grant and that closed, we lost that program. But if we pulled our resources together and we started working together more in collaboration, we could stretch the money a little bit further. We could overlap our services and we could do better. And the bright spot has been the Get Healthy Scott County Coalition and the Lean Sigma program. We've been working through that, and we just got done training and getting all of our leaders up to speed on that right at the end of about 2014. We were starting to look at what we were going to be doing next when all this hit. Lack of mental health and addiction services. This is for the entire country. The bottom has more, the top has less. This is the bottom. And as you move up, you don't see Indiana anywhere. Nope, still don't see them. By the way, I don't have a pointer, do I? Uh-oh. I won't touch that anymore. National is, I don't know if you can see it or not, it's about a third of the way up the screen there. There we are, 4th from the top. That's not good. So we have a lot of opiate abuse, very little opiate treatment for addiction. Let's skip that. Lack of emphasis on harm reduction. So in our school systems, we don't do a real good job of teaching people how to take good care of themselves. Most of the sex ed in Scott County at least, is abstinence only. They won't teach anything else but abstinence. And that's great, but even in marriage, you need to have some idea of what good family planning is. So it's not the answer, and you don't know what your spouse is doing outside the home. I'm sorry. Being able to know how to protect yourself is really important. So abstinence is great, but it's not the only thing that's going to keep people from getting pregnant or getting some sort of infectious disease like HIV. How HIV is spread. Nobody in Scott County knew how HIV was spread. Leaders, we're talking people with college degrees, didn't understand that you can't catch HIV from drinking after somebody, for example. We didn't get the community ready for this sort of thing. Okay, so we're going to move through this really quickly, so I want to get to the end. So in early December was our first case. Indiana State Department of Health announced the outbreak on February 18th. Hattie Hoffman, the health department, announced an emergency meeting. We held that meeting and started working with state and local officials for a response. March 11th, the cases were up to 45. We knew we had a big problem. The nearest HIV clinic was in Louisville, so I reached out to the Indiana State Department of Health and said, we need a local response. Help us develop an HIV clinic right in Austin. We started working with them, the CDC, and others to do that. One of the biggest helps in that has been one of my office managers, Jeannie McCarty, who's been, I can't even tell you how important in this with connecting people to resources. She's not a care coordinator, but she's acted as one, and if it wasn't for her, we wouldn't have nearly the number of people in the treatment as we do. And AIDS Healthcare Foundation, who came in and provided us the much needed funding that we needed. We got nothing from the federal government, we got nothing from the state as far as funding. We're a private, small rural health clinic that was already strapped for resources. If it wasn't for our AIDS Healthcare Foundation, we wouldn't have been able to do what we've done. You all know the barriers to care. To everyone that would listen, I said that the three things we had to do is make it sustainable, make it directly linked to local resources where it wouldn't work, and to make it about patients. We had to listen to the patients. On March 26th, the governor announced the executive order, and just 5 days later, we opened the fully comprehensive HIV clinic in Austin, a great success. We'll move forward. Some unfortunate events occurred around harm reduction, a lot of misunderstandings on how that works because we haven't invested in education from both the sheriff department, local health department, and others, to where people who were getting clean needles were still being arrested, for example. But we've moved through that, we've processed that. April 28th, we were up to 143 cases. We continue to work with the Department of Mental Health and Addiction and SAMHSA to try to bring additional addiction resources to the community. And I'm proud to say that with the help of the AIDS Healthcare Foundation, my staff, local and state government, we've been able, and especially the faith-based organizations as well in the community, we've been able to establish most people into care. We're a little bit over 50% now. Move forward to that. Through the transition from the state coming in and being in control of everything, transitioning it over, there was a lot of tumultuous times during that, a lot of people wanting to be in control, the local health commissioners not understanding the issues, wanting them to just be put away, and the local service community understanding them and needing to connect to the resources. So there was a lot of conflict during that time, but we've eventually come together, and through the Get Healthy Scott County Coalition, again, we've reformulated. We met just a few Thursdays ago for an all-day summit where we recommitted to one another to break down these different silos where people are trying to be in control of different parts of the response and bring all that together under one coalition to where we're working together and the same patient getting services at the mental health institution or wherever, the hospital or my office, we're all communicating because that same person is getting the care under all of those different places. So we shouldn't be fighting over them. Let me move forward. As of June 26th, there were 172 cases. 168 were traceable. 126 were engaged in care. 114 were enrolled in care coordination. 73 were being prescribed antiretroviral therapy. 25 have been virally suppressed already. That's a quick response. 89% were co-infected with hepatitis C. Since then, we've continued to work with people, and you can see how we stack up nationally. So nationally, in treatment is only 39% compared to 75% where we're at. On antiretroviral therapy, 35% versus a little over 50% at this point. Virally suppressed, 30% versus a little over 40% at this point. This is the way it looks. People diagnosed, engaged, prescribed, virally suppressed. Blue is nationally, the green is us. I'm going to move forward. Collaborations are best. Primary care does the best job of treating chronic diseases. That shouldn't even have to be something that's said. So some questions I want to ask you. Are we listening to the people that we're servicing? They already oftentimes know the answers before we do. We listen to them. We'll get to them a little bit quicker. Are we changing the trajectory of communities? Are we collaborating and finding innovative ways to move forward? So Professor Alexander showed that addiction is more about the environment than the rat. Those studies at the beginning of the presentation. Can we invest in a rat park in Austin? Obviously, we don't want to name it that. Population health shows that environment is more than 50% of someone's health. Healthcare, 10%. Where someone lives, you can track it. The most important number for someone's health is not their blood pressure or their LDL level, it's their zip code. And that's the truth. Kids are growing up in Austin are being exposed to repeated childhood traumas. Remember that increases their chances of using IV drugs by 4,600%. Then they're moving on into a lifestyle where they're not finding those bonds that they need. Their parents are in prison or in jail or on drugs and they're not available to them. You have attachment disorders where people haven't bonded healthily with other people. You have the stigma of being poor, the stigma of being addicted to a substance. You have the stigma of being arrested and then on to prison, and now you have a felony and you can't get a job. Just trauma on top of trauma on top of trauma. This exposes hurting, desperate people to not bonding with people, but bonding with a substance. If addiction is a twisted form of bonding, as Peter Cohen claims, then the opposite of addiction is not sobriety, it's healthy human connection. What if the difference between being addicted and not being addicted is the difference between feeling that Austin is your park or your cage? That's it. Any questions?